Good morning, everyone. This is Tony McDowell. I'm the Executive Director for the Opioid Abatement Authority, and it's my pleasure to welcome you to today's installment. Today is August 29th, to our installment today of the Virginia Opioid Abatement Authority's Abatement Academy, which is a series of free presentations designed to help communities identify strategies for addressing the opioid crisis. This series features speakers who have voluntarily agreed to contribute their own time to share examples of best practices for opioid abatement and remediation strategies at the community level, as well as for the OAA to provide technical assistance for you in applying for OAA grants. Today's session features two representatives from the Virginia Department of Health to present information about the statewide naloxone distribution strategy. Before I introduce our speakers, just a couple of housekeeping items. First, if you have any questions, please type them into the Q&A feature, not the chat feature, but into the Q&A feature. And as moderator, I will pose those questions to our speakers. Also, this webinar is being recorded. Both the recording and the presentation itself will be posted on the OAA's website as soon as it's ready in a couple of days. It'll probably be, with Monday being a holiday, it'll all probably be posted on Tuesday. At this point, I have the honor to introduce our speakers. First, I'm going to introduce Ms. Carolyn Lemire. Carolyn earned her master's degree in public health from the University of North Carolina at Chapel Hill and has 10 years of experience implementing human services programs. Prior to joining the naloxone distribution program in 2023, she served on the COVID-19 testing team at the Virginia Department of Health. In her current role, she serves as the strategic program manager for the naloxone distribution program, where she develops program strategy, manages VDH's relationship with partners receiving naloxone, and manages state and federal funding for the program. We are also joined by Dr. Alexis Page, who earned her Doctor of Pharmacy degree from the Ohio State University and completed both a residency and fellowship in community-based pharmacy leadership and management at Virginia Commonwealth University in collaboration with Kroger Pharmacy. She began her career as a community pharmacy manager before joining the Virginia Department of Health in 2021, where she played a pivotal role as the pharmacy lead during the COVID-19 vaccination rollout. Dr. Page has since taken on various critical roles within VDH, including serving as the lead emergency preparedness pharmacist, where she has been instrumental in responding to multiple outbreaks across the Commonwealth. Dr. Page currently serves as the Deputy Director of the Division of Pharmacy Services at VDH, and in this capacity, she oversees pharmacy operations, manages the naloxone distribution program, and provides clinical consultation to support various Virginia Department of Health initiatives. Now, unfortunately, Dr. Page has been having some technical problems connecting to the call, and so we will continue to try to help her get connected, but she did help in putting together the presentation, and Carolyn and she have collaborated on it, and Carolyn, if need be, can do the entire presentation. And so with that as an introduction, Carolyn, I'm going to go ahead and turn it over to you.
Thank you very much, Tony. I appreciate that introduction. I think you have our slide deck if you want to begin advancing. Wonderful. We are just thrilled to be here from the naloxone distribution program. We collaborate with many partners across the Commonwealth, and we also often work really closely with the OAA. And our hope today is that you're able to walk away with a clear understanding of the different opioid reversal agents that are on the market, as well as a better understanding of our naloxone distribution program and how you can access opioid reversal agents to meet your various needs. Next slide, please. So we're going to take you through, first of all, when I say what opioid reversal agents, what am I talking about? What are the opioid reversal agents that are on the market? As you're thinking about your needs whether that's at the city level, the county level, the state agency level. What are the opioid reversal agents that might best meet your needs? What are some of the things that you should be thinking about? How can you access opioid reversal agents? And then how do you fit these agents into your opioid response strategy? Next slide, please. Just begin talking us through the presentation while we're waiting for the slides to come up. So our first item are, what are opioid reversal agents? This might be a new phrase to some of you, but you all know what opioid reversal agents are. The most common one, the most commonly used term is Narcan, is an opioid reversal agent. Narcan is the brand name form of naloxone, and we're going to get into what exactly these are in the future. But basically, the name is a really good descriptor of what it does. So if a person is experiencing an opioid overdose, the opioid reversal agent will bind to the opioid receptors in their brain, causing the opioid to release and reversing the effects of the opioid overdose and potentially saving the life of the person who's experiencing the opioid overdose. Taking a step back, what are opioids? That could be oxycodone, fentanyl, heroin. You could have a synthetic version like fentanyl, or a non-synthetic version like heroin. And opioid reversal agents work on both synthetic and non-synthetic. So there are generic and brand name opioid reversal agents. They're available as prescription products under the standing order. And they also, there are several versions that are available as over-the-counter products as well. So what are some of the opioid reversal agents that are available? We can consider these in two broad buckets. We have naloxone as an opioid reversal agent, and we also have nalmefene. Now, both of these products, it's very important to note. Here we go. We're back again. Can we go to slide 6, please? Both of these agents, it's very important to note, they will not hurt a person if they are actually not experiencing opioid overdose. If they, for example, you think it's an overdose, but it's an allergic reaction, or they're overdosing on something that is not an opioid, no harm done. The downsides are very low. You may need, depending on the dosage, to use more than one dose of an opioid. And you should always make sure to space doses by 2 to 3 minutes. The one risk associated with these opioid reversal agents is opioid withdrawal syndrome. Now, this is actually not a side effect of the opioid reversal agents. The opioid reversal agents do not have side effects, but opioid withdrawal syndrome is caused by a person who's experiencing overdose, and then when the opioid reversal agent is administered, they immediately begin experiencing withdrawal. So those symptoms can include vomiting, tremors, sweating, rapid heart rate, and headaches. And the risks of this withdrawal syndrome they can be higher with higher doses or shorter intervals between doses. So if a person is administered several doses back to back, instead of waiting the 2 to 3 minutes, they might be more likely to experience opioid withdrawal syndrome. So thinking about naloxone versus nalmefene, they work in very similar ways, and they have several administration methods that are very similar. The naloxone, the rapid onset is 3 to 17 minutes. Literature does suggest, and use in the field, if anybody has used this product, the actual rapid onset is much sooner than 17 minutes, but that's what the published literature shows. Compare that to nalmefene. The rapid onset is a little bit faster, 2.5 to 5 minutes. Time to peak for intranasal naloxone is about 20 to 30 minutes. Again, nalmefene a little bit faster at 15 minutes. And the duration of action of intranasal naloxone is 30 to 120 minutes. And nalmefene, that is not available. The reason for that is that naloxone has been available since the 1970s. So it's been used quite widely for quite a long time. The nasal naloxone product in the form of Narcan was the first one. This was made available several years ago, so it's very well understood as a product. Nalmefene is newer, and especially the nasal nalmefene is very, very new. So some of the ways that it's actually going to work out in the field, in the real world. We're still learning about this, right? So as we're working through this presentation, just want to keep everybody aware that this is a snapshot in time. This is what we understand about these drugs now. These are the drugs that are on the market today. If we were giving these presentations, this presentation in 6 months, there might be a different suite of products and there might be more research that's available. So we really try and stay current, and we try and also be a good resource for everybody who is trying to learn about these products as well. Okay, the next slide, please. Okay, Narcan, as I mentioned, it is the first needle-free, so nasal version of naloxone. Narcan is the most familiar brand name, and it's the same way that people might say Kleenex or Xerox. It is actually a brand name for naloxone. It is a 4 milligram nasal spray, and it is available for purchase over the counter. So it's been available over the counter for a little bit under a year. One box has 2 single sealed doses in it, and it's about $40 to $50. It's coming down a little bit, and $40 to $50 would be the retail price if you're walking into a community pharmacy or buying it online. That's about what you would pay. You can purchase it over the counter. We also do maintain a standing order, so you can purchase the prescription version at the local pharmacy as well. How do you know if you have a product? How do you know if it's prescription versus over the counter? The prescription product, you can see we have a little box on here. It says RX only. All prescription products will say RX only on it. So if you have a box at home, take a peek. And that's how you'll be able to tell, do you have the prescription product, do you have the over the counter? The formulation is the same. It's the same product that's in the prescription box and in the over the counter box. The difference is the packaging. The over the counter packaging has instructions for use, additional information on it. The prescription does not have that printed, but it needs to be provided by the person who provided the prescription. So that's why if you have handed out naloxone in the past, the prescription product, there's a lot more rules about what you have to do. You have to, make logs of people's names and complete a product label and all of that. That's not a requirement for over-the-counter naloxone. Next slide, please. We also have a generic naloxone. So what's the difference between the prescription, the Narcan and the generic? They're pretty much the same. Both 4 milligram, both a nasal spray. They're both available prescription or over the counter. The generic, as most generics are, a little bit cheaper. One thing to note, however, is that currently the shelf life for Narcan is about 5 years. And for the generic, I think they're working on getting their 2.5-year approval for their shelf life. So the generic, it just hasn't been around for as long. So if you're doing shelf life studies, it just has to be on the market for long enough, right, to be able to demonstrate its effectiveness for a longer period of time. So if you're thinking about what product is a good fit for you, price is a factor. Shelf life is also an important factor. Next slide, please. Here's another naloxone product, the Revive. Very similar to the previous two, but while those are 4 milligram, this is a 3 milligram spray. And so this is produced by the manufacturer is called Harm Reduction Therapeutics. They're actually a nonprofit drug manufacturer. And kind of their thinking is they are really concerned about this opioid withdrawal syndrome. So they're thinking a little bit of a lower dose could be less likely to have people experience opioid withdrawal syndrome. They're mostly selling to harm reduction organizations and state governments. So this is not something that you can walk into a community pharmacy and pick up off the shelf, but it's a product that is available. And if this is something that you are interested in, you certainly could inquire to see if you would be eligible to purchase. Next slide, please. Okay. Here's another naloxone product, if you're keeping track, our 4th naloxone nasal spray, and this is an 8 milligram. So the Narcan and the generic naloxone, those were both 4 milligram products. So an 8 milligram is basically a double dose of the Narcan product. Kloxxado is the only form. So it's only this brand name Kloxxado. There's not currently a generic 8 milligram. It is FDA approved pretty recently. Also, very similar to the 4 mg product, it comes as 2 individually packaged 8 mg doses. So when you buy a box of Narcan, you're getting a total of 8 milligrams. If you're buying a box of Kloxxado, you get a total of 16 milligrams. Kloxxado is a prescription-only product. There's no over-the-counter formulation, and that's just because, as we talked about, it is a stronger formulation, and so it's more likely to cause this opioid withdrawal syndrome. And so that's why at the moment it's prescription only, but it is available on Virginia's standing order, which can help promote access even to these prescription products. And it is a little bit more expensive. If you're buying it, again, at a pharmacy, you might pay $90, $100 for this product. Next slide, please. Okay, moving on from naloxone over to nalmefene. The nalmefene, you can see that the spray, it looks exactly like all the other ones, right? It looks exactly like the Kloxxado spray, but this is actually an entirely different drug. It's nalmefene, 2.7 milligrams, but this cannot really be compared to the 4 milligram or the 8 milligram of naloxone because it's a different drug. So the dosing is different. This is very, very new. It was only approved in May of 2023. And important to note that it was only approved for patients 12 years and older. So this is an important distinction compared to the naloxone products where there is no minimum age. They're able to be used on a newborn. That is not the case for OPVEE. Again, this is a prescription product only. Very, very new. Still trying to figure out, how I think the FDA is maybe considering. I actually don't even know if they've applied for over-the-counter status. A little bit more expensive compared to some of the lower dose naloxone products, maybe around $60. Because this is a very new product, there are several medical associations that have put out publications that describe naloxone as the drug of choice. Doesn't mean that OPVEE doesn't have a place in opioid response, but we just wanted to share that as if we're sharing research findings, this is an important one as well. Next slide, please. Oop, you missed one. Okay, Zernae is so new. It was only approved a couple of weeks ago. It's so new, we don't even have a picture for it. It is an auto injector. So an auto injector you might be familiar with is an EpiPen. So this is an EpiPen kind of version of nalmefene. So again, approved only for patients 12 years and older, prescription product only, covered under the standing order, but it's so new that they are, it's not available for purchase yet. If you're walking into a community pharmacy and asking for this, they're not going to have it. But as you all are kind of thinking about your plans for the next several months or potentially next several years, this might be something that's just important for you to understand as part of the opioid reversal agent landscape. Next slide, please. Okay, so which opioid reversal agents are the best fit for your needs? It depends on what your needs are, right? So depending on what you are trying to do, different products may be more or less appropriate compared to one another. So next slide, please. Some things to consider. Price. If you're trying to access abatement funds or use other funds, you want to make sure that you're using these funds responsibly. So the price is obviously going to be an important factor. Ease of access, over-the-counter versus prescription. There are some things that you can do with over-the-counter product that you cannot do with prescription product. So for example, you cannot put prescription product in a vending machine. If a lot of folks are really interested in vending machines right now, if that's a place that you're interested in, you have to consider an over-the-counter product. Shelf life is an important one. Depending on what you're intending to do, for example, if you're trying to put a product in an office somewhere as kind of a just in case somebody comes in with an opioid overdose, you might want something that has a longer shelf life. And then the likelihood of precipitated withdrawal, that's always a factor that should be considered. Next slide, please. Here, just a few hypothetical examples. So we have City A, they're wanting to put their opioid reversal agents in all of their first aid kits in all city buildings. So this is more of a just in case kind of use. They're not necessarily expecting that people will be presenting with suspected opioid overdose in these settings, but they want to be ready just in case they are. So the priorities, ease of access is really important. You have to make sure that the product is over the counter in order to put it in a first aid kit. So that narrows us down to the naloxone products, which are the over the counter products. And shelf life, a later expiration date will save money in the longer term. So even if you are paying a little bit more upfront, you might save money in the long run because the shelf life is longer. You're not needing to replace it as frequently. So City A decides to purchase Narcan for this purchase because it's an over-the-counter product that has the longest shelf life. County B is thinking about vending machines. They want to stock these vending machines with opioid reversal agents and other harm reduction supplies. So their priorities are ease of access. So again, needs to be over the counter to go in a vending machine, and price. They're expecting that, the product is not going to sit in the vending machine. It's going to rotate out. People are going to take it and people are going to be using it. So they're not as concerned about shelf life. They're more concerned about price. A lower cost to the product means that they'll be able to purchase more and hopefully keep up with the demand. So County B decides to purchase generic naloxone. So it's really important to note that just because City A and County B are purchasing different products, it doesn't mean City A is right and County B is wrong, or vice versa. They have different needs and they're purchasing different products that meet those different needs. So as you are thinking about, I would really like to access some opioid reversal agents, be clear about what your needs are and think about what products are most likely to meet those needs. Next slide, please. How can I access opioid reversal agents? Great question. Next slide. So we do have a no-cost naloxone distribution program. This past fiscal year, so ending in June of 2024, we distributed over 140,000 naloxone kits to almost 650 partner organizations across the Commonwealth. If you're interested in our strategy for naloxone distribution, we have our naloxone distribution and saturation plan. This is available online. I think these slides will be circulated afterwards, so you'll be able to access the link. Here's a little bit of a summary of what our month-to-month distribution looks like, and also what types of organizations are receiving the bulk of our product. So if you can see in gray, we have our authorized comprehensive harm reduction sites receive quite a lot of product. In yellow, community service boards, they also receive quite a lot. Green, community-based organizations. And then another one I'd like to highlight is in orange, we have our local health departments. All of our partners are really critical to our naloxone distribution efforts. You can see there's a little bit of a seasonality where our K-12 schools, for example, in November, December, January, they're a little bit quiet. But we have some partners that are receiving product from us consistently and really getting it out the door to folks who are in great need. Next slide, please. Now, we do not have an unlimited supply of naloxone, right? We distributed 140,000 kits. That's not enough for every single person in Virginia. So how do we decide who is eligible to receive naloxone from our program? So our current focus is we think about high priority populations and settings and individuals. So when we're thinking about high priority or high risk individual, we're thinking about people who use drugs, friends, family, and caregivers of people who use drugs, and people who work with people who use drugs, right? So thinking about people who use drugs at the center, and then thinking maybe, a couple of circles around them, people who are interacting with people who use drugs. The way that we provide naloxone is we provide it to eligible organizations who then provide it to eligible people. So our eligible organizations include harm reduction sites, community services boards, local health departments, correctional facilities, first responders, public K-12 schools, and other community organizations that have high levels of interaction with people who use drugs and their friends and family. So if you have some organizations within your locality that fit under this umbrella, please have them get in touch with us. We're especially wanting to increase our reach to homeless service providers, free clinics and FQHCs, other community-based organizations that have high levels of interaction with people who are likely to experience or witness opioid overdose. So we would love your help in making sure that as many eligible organizations as possible are connected with us and are receiving naloxone. Next slide, please. So you may have some intended uses for naloxone or opioid reversal agents that do not fit within our no-cost program, and that is fine. That's great. If the only naloxone that was in Virginia is what's through our program, that would be really insufficient, I think, to meet kind of the needs of Virginia. So we really need everybody pushing forward to make sure that we have sufficient opioid reversal agent access in Virginia. So what are some ways that you might be able to access opioid reversal agents? We at VDH can provide a quote for you on request. You also can access the state naloxone contract, which is for generic naloxone. That is $35 a kit plus shipping expenses. You also can reach out and seek a quote from vendors directly. Next slide, please. So finally, we just wanted to take a moment to think about how opioid reversal agents fit into your opioid response strategy. Next slide. So opioid reversal agents, obviously we're on the naloxone distribution team. We think they're really important, but this cannot be your whole strategy, right? If all you're doing to respond to the opioid crisis is providing opioid reversal agents, you're just going to wind up in a cycle, right, where you're providing the same products to the same people over and over again. So we really encourage you to consider opioid reversal agents, but also kind of think about how they fit into what else you're doing. So what's happening beyond naloxone? So harm reduction services, are folks being plugged in to other services that they might need in addition to opioid reversal agents, like peer counseling or HIV testing, hepatitis testing? Are they being connected to the care that they need? Are you working with your local partners? This could include local health districts, harm reduction sites, community service boards, and community-based organizations. So obviously we sit at the central office. We really rely on these partners to tell us what they're seeing among their clients. Where are their gaps? Who is still struggling? Are they seeing some new needs that we hadn't identified? So for example, we're hearing a lot of needs for wound care supplies as xylazine and other drugs are becoming more common. So talk to people who are really plugged in to the folks who are in need for these services. And then think about strategy. Who's thinking about how all of these puzzle pieces fit together? How can we all make sure that what we're doing is supporting other activities, not duplicating efforts, that we're not, reaching all the same people and leaving some folks out of the conversation. Next slide. That is all the content that I have, but we would love for you all to reach out to us with additional questions that you have. I know we're going to have a Q&A portion. Please check out our website, vdh.virginia.gov/naloxone, and our email address is opioidreversal@vdh.virginia.gov. So if you have questions about whether you're eligible for no-cost naloxone, if you have questions about what partners we might be working with in your region, we're happy to connect and discuss and get to know you all a little bit better. So thank you very much.
Thank you, Carolyn. So we do have some questions in the Q&A area. So, and some of these may have been answered given the timing when they were asked, but let's see here. To start, can you speak about injectable versus intranasal naloxone? How do differences in dosage impact the people receiving the naloxone? Is one more effective than the other?
Question. So injectable naloxone, it is lower dosage. So the nasal naloxone, it might be 4 milligrams. The injectable naloxone might be 0.4 milligrams, right? So you can tell already that it's a little bit more effective because you can use a lower quantity. Injectable naloxone can work a little bit faster, but some folks, particularly, people who have experienced being revived by naloxone, sometimes they say that the injectable is a little bit gentler. I think that is a qualitative finding. I don't know that it's actually less likely to cause opioid withdrawal syndrome, but some people have a preference for it. The challenge with injectable compared to nasal is it's more challenging to use, right? If you're thinking about an overdose situation, it's a high pressure situation. It can be quite tense. If you are not somebody who is comfortable using needles, it may be very challenging for you to have to take the vial, you insert the syringe, you draw it up, you inject it into the person. It's a lot of steps compared to the nasal naloxone, which is a little bit easier to use. So ultimately, the best product is the one that you are actually going to be able to use in the moment. If I am, as Tony said at the beginning, I'm not a pharmacist. I'm not a clinician of any kind. I've never given anyone an injection. I don't think the first time for me to give somebody an injection is in an emergency situation, right? So for myself, I would choose a nasal product. You might be a different person. You might be somebody who has a clinical background. Sometimes people who use drugs are more comfortable with syringes than the general population might be. So it's just another factor to consider.
Okay, so can you speak about how nalmefene works differently in the body compared to naloxone?
This would be a great question for Alexis, the pharmacist, to answer rather than Carolyn, the master of public health. They work very similarly in that they both bind to the opioid receptors in the brain. I'm not really able to speak to, why it is that nalmefene works a little bit faster compared to naloxone, but I would be really happy to have Alexis provide a response to this that we can send out with the recording following this presentation.
Fantastic. Okay, so it looks like, I think they're asking you, so what about putting on EMS fire units leave behind bags? And I think maybe they're asking whether or not from a storage perspective, maybe.
Love that as an idea. So the leave behind bags, I think that you're probably referring to, Francis, some fire or EMS agencies, after they respond to an opioid overdose, particularly if the person does not want to be transported to the emergency department, they might be provided a leave behind bag that has some resources of here's local harm reduction site, here's some options for treatment. And you might put some naloxone in that bag. You might also put some other products like fentanyl test strips or other types of test strips. We love that as an intervention. We do caution, and the reason I said naloxone is that we would recommend that be an over-the-counter product generally. If it's possible to do it with a prescription product, but it just takes a little bit longer. And we have found that to be a barrier for the EMS and fire units, that it's a barrier that's challenging for them to surmount. So they would strongly prefer the over-the-counter supplies. And so over-the-counter means naloxone at this point. It's a really great idea, very highly targeted, right, to people who are likely to witness or experience an overdose because they already have, right? So it's a great way to anybody who's there, whether that's the individual who experienced the overdose and maybe other people who witnessed, whoever called 911, whomever else might be there. Those are great folks to make sure that they have naloxone and other key products in their hands.
Okay, let's see here. There's a question. Please explain again why a prescription naloxone cannot go in a first aid kit.
Great question. So the prescription product does need to be assigned to an individual. So we do maintain a standing order on our website, and that covers the prescription. So basically the standing order, it's signed by our health commissioner, Dr. Shelton, and basically says people under these scenarios can access naloxone, even if it's and other products, the nalmefene products as well. They can access it without a prescription. However, when you are providing the naloxone, you are dispensing it to an individual. There's additional information that needs to be provided on the kit and collected at that time. That includes the name of the person. You need to, include some instructions for use. You need to keep a log of the lot number and things like that. And so if you're thinking about a first aid kit, if you're thinking about a vending machine is another example, that kind of labeling is not happening in those instances. So, there were some potential kind of workarounds when only prescription product was available, not to put it in a first aid kit because it did have to be securely stored, but you could have some undesignated stock product that you're maintaining in a secure location that you have on site in the instance, ready and available. Should there be a suspected opioid overdose on site. But now that the product is over the counter, we can kind of expand the way that we're using it. And so if you're wanting to put it specifically in a first aid kit, it's got to be the over-the-counter product.
Great, thanks, Carolyn. I think you may have touched on the next question a little bit too, or it's very close. So to be included in vending machines and first aid kits, why does the product need to be OTC? Why can't it be any product that is covered by the state standing order?
Yeah, so same thing, right? That if somebody's accessing a product out of a vending machine, they are not getting a product that has that label on it, right? So the label, it would need to include the patient's name, but also think about, we talked about the differences between the packaging for the prescription versus the over-the-counter. The over-the-counter box has instructions for use on it. So if somebody is accessing product out of a vending machine, you don't have the opportunity to talk to them. You don't have the opportunity to make sure that they know how to use it. Even if you were allowed to put the prescription product in the vending machine, which again, you are not, but if you were, I would still recommend the over-the-counter product just because you want to make sure that anybody who is walking away with that product knows how to use it. And for the over-the-counter, the instructions are right there on the box. So whenever somebody is opening that box to get to use the product, they have the instructions right in front of them, which is what you want.
Okay. So, and I think you've already touched on this one as well, but chemically, what is the difference between Narcan, naloxone compared to nalmefene, and why the change in product for the same purpose?
Yeah, so I think why are there differences in product for the same purpose? I think that's more of a question for the pharmaceutical companies. I think it's something that folks are always trying to investigate and see, we have something, even if you have something that's working, is there something that will work even better? And I think time will tell, is nalmefene that product? Based on the research literature, including responses from the medical community, it seems a little bit early to say whether or not nalmefene is a superior product, but and we can follow up on kind of the chemical and biological pharmacological differences between naloxone and nalmefene after this call.
Right. It looks like the next two might be either just observations or in response to the question that you just answered. But I can go through and if you'd like to provide any sort of commentary around this, what was asked. But so this says the medical community concerns regarding nalmefene center around its much longer duration of action, data from injectable form, which will interfere with acute treatment management, including increased withdrawal symptoms and difficulties starting MOUD agents. So it's, again, it's not a question so much, but just a statement.
Yes. Yeah, that's a really great point. There was a position paper by the American Academy of Toxicologists that raised exactly this concern of, when somebody is in the emergency department following receiving naloxone, they're monitored for 90 minutes. For nalmefene, might they need to be monitored for longer, for 3 hours or 4 hours? And how is that going to kind of interfere potentially with their with the next steps if they're eligible or if they would like to receive other forms of treatment?
Right. And So this is again more an observation about I guess the effectiveness of some of the different varieties of drugs and dosages. But in a study with the New York State Police, 8 milligram naloxone did not improve outcomes in opioid OD cases over 4 milligram. The 8 milligram dose was associated with greater incidence of withdrawal syndrome.
I think that's a really great point. And I see these comments are both from Dr. Green, who is very, very well versed in the research. And I really appreciate you putting these in the chat, Dr. Green, to give us the opportunity to talk about them. That's a really great study. It's the CDC published this as an MMWR. If you would like to look it up, it's the first, as far as I'm aware, head-to-head comparison of 8 milligram naloxone versus 4 milligram naloxone in the field, right? So in the real world setting, compared to many of these studies are taking place in labs, which, as we all know, maybe that's a good comparison and maybe not. And so another interesting thing about the New York study is the police, whether they were using the 8 milligram or the 4 milligram, they actually used the same amount of both products. You would think the 8 milligram, you can use half as much, but in practice, that's not what was happening. And so I personally kind of wonder if this is due to the fact that when people are talking about opioid reversal agents, they say Narcan, right? And people don't differentiate. The same way when you say, oh, can you pass me a Kleenex? You're not necessarily going to look at the box and say, oh, actually, this is a Puffs, right? It doesn't matter if it's a tissue. It does matter if these are actually different products with different doses, right? So that's something, again, as you're thinking about what products are a good fit for you, think about who's going to be using them and are they going to be able to differentiate between different dosing? That's something that's really important to consider.
Great. And looks like we've got some more here. So which products does VDH currently offer through its free naloxone distribution program? And are there any plans to expand the options that are offered?
Yes, that's a really great question. So currently, the vast majority of what we distribute is 4 milligram generic naloxone. This is because a lot of our product is going out into the hands of the community. So for us, the lower price is the bigger consideration. We also distribute a small amount of injectable or intramuscular naloxone, and that is exclusively to comprehensive harm reduction sites. There are several that they have clients that strongly prefer intramuscular naloxone, and so we think that it's really important to respect that choice, and that also that product is quite a lot cheaper compared to the nasal naloxone. So that is something that we have been doing. I think we have been doing IM since January. In terms of what products will be offered, we certainly, as research develops, we're always kind of keeping an eye on what research is saying about the different products. We also are always keeping an eye on shelf life and prices, right? So if right now the generic is enough cheaper that we strongly prefer purchasing that over even a name brand product that has a longer shelf life, that calculation may change in the future, right? As prices change, as shelf lives change. Another thing that will change is that in the state budget, we received some money to purchase naloxone, and a portion of that was designated specifically to purchase 8 milligram naloxone. So, which there's one form of that currently, Fluxado, that we talked about. It's a prescription product. So we are investigating what exactly that's going to look like and whom we think is going to be the best fit to receive that. But that is something that is that we are currently working on.
All right. So this is interesting. So should we be asking what the product dating is before receiving versus just assuming that Narcan has a longer shelf life over others? I'm assuming that others will have a longer shelf life very soon at a lower price. So that's kind of an interesting thing to contemplate there, right?
That's a great question. And additionally, just because a product has a longer shelf life from the date of manufacture, you're not getting the product the date that it was manufactured, right? So if you're inquiring even if you're inquiring to us, if you're inquiring to the state contract, if you're inquiring directly to a vendor, always ask what the shelf life is, because it could be, oh, we're going to cut you a great deal on this generic product. And why is it a great deal? Because it's expiring in 6 months and they're just trying to get it out of their warehouse, right? Always ask about the product dating, and think about, what is actually going to be practical for you. And you're very correct that the shelf life, it's always changing. So just because currently the Narcan has a longer shelf life, that may not always be true. So definitely important anytime you're making a purchase to inquire what the shelf life is in general for that product, as well as specifically for the shipment that we are going to receive. What is the expiration date on that product?
Great. And this is just a few more questions here. So we've got, this is from Francis again. So in the context of EMS kind of fire type use. So are there any special requirements? Can they just buy OTC Narcan?
Yeah, over the counter. So another over the counter product is Tylenol. So anybody who can buy Tylenol can buy over the counter Narcan, right? I would also encourage the fire EMS, have them get in touch with us. We would love to supply to those programs for that purchase. So you can see our email address is right on the slide there. We would really, really love to connect with any fire EMS agencies that are working on leave behind bags.
And it looks like we may have had an answer related to the kind of the biological effect difference between nalmefene and Narcan. So if you'd like to just read that or comment on their response, or I don't know how you want to manage that.
Thank you, Jason, for saving the day. Nalmefene has a higher affinity for the mu receptor, so it will remove the opioid with higher efficiency, which can cause more precipitated withdrawal. So data suggests it is 4 times as potent as naloxone. So thank you, Jason, for including that. And, think about 4 times as potent. Do you always need a product that's 4 times as potent? Sometimes maybe not. Right. So as Jason said in this instance, more potency, it has benefits, but there are also downsides in the form of precipitated withdrawal. And I see that Jason included an article there. Thank you very much, Jason.
Yeah, and I'd also like to add, we the OAA working with VDH will answer all of the questions, the more technical questions that were asked. That weren't able to be fully answered here during the webinar, and we'll post those to the website for everyone to have access to later. So let's see. So I work with a nonprofit coalition partnering with local CSB, VDH, Free Clinic, DSS, Homeless Services, Transportation, and Community Colleges. I provide Revive training to staff and community members and students. How do I best provide naloxone to participants?
Please email us, and we'd love to talk with you specifically about your efforts. I will say that most of those organizations, they can get naloxone from us directly, so you may not need to be the one who's ordering and distributing the product. But we love talking with anyone and everyone. So please get in touch with a little more detail about your specific scenario.
Great. And this is not so much a question, but someone just kind of shouted out they appreciated you providing the clarification regarding considerations of different products for different projects and activities. And let's see. So do the prescription versions not have the instructions on the box? And I think you mentioned this already, but.
Yeah, the prescription versions do not have instructions on the box.
Okay, I'm just getting down to this. Let's see here. Okay, so are you aware of jurisdictions that have Narcan and county first aid or nalox boxes as part of their employee safety efforts? Over-the-counter medication in places like local government offices, libraries, community centers, etc. This person is working on an effort that would include a brief employee training and would like to learn from other jurisdictions that may have this as a part of their employee training policy, site first aid safety station. I don't know if this was intended to be to the group or for you to respond to specifically, but if you have anything to add, Carolyn.
I am not aware of jurisdictions that have this specifically as a policy. I'm sure that there are some that have this as a practice. But I think this is something that is maybe in early initial stages in many localities. So Marla, I would be very interested in seeing whatever policy or training you develop, and to see if maybe we could play a role in helping to circulate that, for example, to post on our website or put it in our newsletter so that other folks who are looking to do similar things could have access to your resources. So I'd love it if you could get in touch as well.
Perfect. Okay, so it looks like we've got about 5-6 minutes here and just a handful of questions left. So there was and I'm sure this is an acronym of some kind, JAMA study that found that administering 8 milligram upfront reduced the period the individual spends in a hypoxic state and reduced the risk of cardiac arrest. Can you speak to that study?
I cannot without looking at that study specifically. I think this is another question that Dr. Page would be better positioned to answer based on her clinical background. I do know that cardiac arrest is a very rare. It can be quite rare. When it's related to precipitated withdrawal. So it could be perhaps reducing a rare event while reducing the risk of a rare event while increasing the risk of a common event like other withdrawal symptoms like vomiting. Is that a cost benefit analysis? But I think this is another question that, as Adam said, we can send a more detailed response in the follow-up.
Okay. Can you elaborate on why 8 milligram naloxone was included in the state budget?
Yeah, I cannot. The state budget was written by the legislature, so no,
Yeah.
I can't.
Yeah, we don't. There are many reasons why things end up in the state budget, and that is it's up to the legislators to decide that, and then the governor decides. So we couldn't really that. So with regards to the New York study, the authors compared multiple doses of the 4 milligram to multiple doses of the 8 milligram. It was not a head-to-head comparison. Multiple doses were administered because the police frequently give 2 doses without waiting. This is a training issue. Oh, interesting.
Yeah, that's a really great point, Desiree. It can certainly be a training issue. But I also think it's important to consider that in the real world, people are not always going to act in the way that they're specifically supposed to, whether they were trained or, whether it's the instructions on the box. And so can we collectively be thinking about setting up systems that are flexible and that are able to accommodate even if somebody is not acting in exactly the right way that they were trained, while also promoting solid good training to make sure that these incidents are less common.
Great. Here's again, we're going to wrap up here in just a few minutes, but here is a question. It looks like on the kind of the duration, the efficacy of the over-the-counter products. So it says, do the OTC products you are sending to outside organizations, should we dispose of them based on the expiration date?
Please send them back to us and we will dispose of them.
All right. Kloxxado does have instructions on the back of the box.
Thank you. We don't currently distribute Kloxxado, so I appreciate that comment.
Okay, and this is an observation by Dr. Green. Being labeled non-research is a procedural decision as to whether a study requires IRB approval. It does not invalidate a study's results. And let's see here. I'm just scanning through. Oh, and someone provided Journal of the American Medical Association channel. Perfect. Okay, I think that Someone didn't, it looks like someone mentioned that the prescription versions do have instructions on the box.
Hey, Adam.
Yes, sir.
Hey, just to jump in real quick, this is Tony, and I wanted everyone on the call to know that, well, first of all, thanks Carolyn for doing a great job. Her colleague, Dr. Alexis Page, who is the pharmacy manager, was slated to be a speaker, and I think Alexis would have been the right person to answer some of these more computer issues and wasn't able to stay on the call.
Sorry about that. My Zoom kicked me out, so I don't know if there was any
Oh,
final thoughts. I'm back.
I was waiting for Tony to finish. Yeah, I was just saying thank you to you, Carolyn, and thank you to Dr. Page, obviously, for standing by and attempting to overcome the logistical and technical obstacles so she could join us. But we will follow up with the answers to some of those more complex questions and post them to our website later for the attendees and anyone else who would like to see them, review them, and yeah, just generally speaking, the OA and VDH are always around to answer questions and help out in any capacity that we're able to. So, do you have any closing remarks, Carolyn? Or
So we are so appreciative for everybody who has taken the time to come and learn about these products. I know maybe 20 minutes on different types of pharmaceutical products sounds like a little bit of a dry morning, but we really appreciate you all coming because it is important, right? And as you know, Dr. Green is saying in the chat that these products they have different prices, they have all different formulations, right? And so we really want to make sure that you all have the information that you need to make the decisions about what is right for you. We're not here to tell you what the correct decision is. You know, all these products are either over the counter or they're on the standing order to allow you to make your own decisions, but we want to make sure that you have as much information as is available to make these decisions for yourself. So as Adam and Tony were saying, we'll make sure that Dr. Page is able to review some of these questions and send around some of the more technical background that some of you were asking for, but I hope that you did find this helpful. Please do reach out with any questions either about different products or about our program, and we're looking forward to continuing to work with all of you.
fantastic. Thank you so much, and thank you everyone for attending.